Okay, welcome back, everyone. We are we're in the home stretch, both for the final uh, portion of the course, but also for the final portion of this lecture. So this is our last lecture on gender and sex issues, and we're going to start talking about transgender and LGBTQ issues. And later we'll be talking about men's issues. Again, I recognize that it's a minimal part of the course, in as much as I would like to dedicate, give it, just as the whole course could take several more weeks if we went into more depth on any of these issues. But also more importantly, as I mentioned in the beginning of the course, men's issues are pretty much dealt with in a way in every other course in the class, in that most of this research on psychotropic medications is done on men, on males. And so I do believe that proportionally, we needed to spend more time talking about women's issues and, of course, transgender and LGBTQ issues. So we're going to start off with some terminology. We're going to talk about some issues that are that could potentially present from a psychopharmacological perspective, certainly from a psychiatric or psychological perspective, with individuals who are transgender or LGBTQ, or yeah, somewhere in the non-gender binary spectrum, for lack of a better way of putting it. And also some resources that you can utilize to help you manage clients who belong to this groups, especially depending on the setting, especially if this is something that you encounter. If you work with adolescents, it's probably something you encounter. If you work in the prison system, it might be something that you encounter, and certainly in other practice, in other settings for clinical practice, it may be something that you need to know as well. Sorry, I just forgot to put my phone on do not disturb, and I want to make sure to, give you my full attention. Okay, so without further ado, we're on slide 302 of the gender slide set. Let's talk about some terminology. If you are not familiar with the gender unicorn, or some other, graphic way to, talk about these issues or discuss these issues, especially again with adolescents or children or adolescents, but certainly with parents or adults, I highly recommend this graphic. It really is beneficial in helping somebody understand what we're talking about. So as you could see, it defines gender identity as either female, woman, girl, male, man or boy, or other. In other genders, again, some people would, there's a lot of terminology that may be associated with that, from gender neutral to all kinds of expressions, which again, or not again, but it's probably not the intent of this course. What I would recommend is that you establish a conversation with your patient in which they provide you the terminology that they're comfortable with or that they prefer using for themselves. Realize we have a little bit of a glare, and I apologize for that. Hopefully it's not too bad. Okay, gender expression is feminine, masculine, or other. And again, there could be a lot of terminology associated with that. Um, Sex assigned at birth, it's a term that we used earlier in the class. It's either female, male, or other, as in intersex. That's chromosomal sex, not gender. Gender, again, it's a socio-cultural construct, not a biological construct. So sex is primarily biological. Again, it's chromosomal, female, male, or other. Um, Physically attracted refers to sexual orientation. So that is not gender identity, not gender expression, but sexual orientation. Somebody can be physically attracted to women, men, both, or other, again, non-gender specific individuals. And somebody can be emotionally attracted also to women, men, or other genders. And all of that, as you could see from this graphic, is on a continuum. So once again, this is a really good visual cue that incorporates, your knowledge, not just your knowledge, but your openness to talk about these issues. And I highly recommend that if you, again, treat adolescents, their parents, or even adults with who are part of the LGBTQ community, that you display this graphic in your office as a means to open up a conversation and be willing to answer questions, but also to ask questions again about their own identity. Um, so, as you recall, when we talked about gender sensitive pharmacology, uh, just like we did with culturally sensitive psychopharmacology, our goal is to make sure to incorporate the knowledge of sex and gender variables into clinical decision making, into research, medical education, therapy, and treatment planning. And that means that we have to take into account several factors, right? Do we have a welcoming environment where people can who are non-gender binary or who are part of a sexual minority can recognize themselves as welcome, can see that they have a place or they can fit in, or that they can talk about these issues, and this is, we can have visual cues such as the gender unicorn or rainbow signs or flags. We could have policy or non-discrimination statements that are posted on our waiting areas or available to patients or their requests. We could have other symbols such as flags, pins, or lanyards. We could have observances. We can display observances such as, observation months or observance months, materials, and that sort of thing. Education materials about reproductive health or sexual health, language, our intake paperwork that signifies that we're not, again, when we talk about gender, sexual orientation, gender identity, we don't expect that there's one or two sizes that fit all, but that incorporate, the ability for other people to express their identity. Um, we can, make sure to have an openness in our language to address people by a different name that perhaps their given name, especially if they're transitioning and they haven't yet completed older demographic markers transition. It may be that, a person may request that we call them by a different name from their given name. And we need to, it's a good idea for us to be open to that. And of course, it's always a good idea to acknowledge, apologize, and correct any misinformation or mistakes that you make, because all of us are likely to do that. For example, when you ask somebody if their wife or husband, a question about their wife or husband, and you assume, a um, heterosexuality construct or heterosexuality situation is going on. Um, okay, so sorry, I just kind of I know I talked a lot on that slide. I just wanted to give you some information about kind of starting at the beginning, how to make it a welcoming environment, and you guys, probably have some experience with that. And if you do, and if you're willing to share in your discussions or separately, you're more than welcome to do so. So, in case you didn't know, uh, there's a World Path or WPATH, which stands for World Professional Association for Transgender Health. They come up with a statement every so often. There was one in 2010, and there is the newest one in 2022. That really is the equivalent, not exactly, but the equivalent of a clinical practice guideline where it comes to the management of transgender issues in clinical practice. And this includes medical as well as psychological or psychiatric. It is not specific. The W path is not specific to psychotherapy or psychological issues. It includes endocrinology, uh, surgery or, other medical professionals, guidance for other professionals that may interact with transgender individuals. Um, in 2010, they certainly argued for the de-psychopathologization, so depathologizing of gender nonconformity worldwide. And I think relatively speaking, we have made some strides in the idea that or transgenderism is not a disorder. Gender dysphoria is still, a disorder in the DSM. However, they really argued for diversity versus diagnosis. And you could see the quote in front of you on slide 304. The expression of gender characteristics, including identities that are not stereotypically associated with one's assigned sex at birth, is a common and culturally diverse human phenomenon that should not be judged as inherently pathological or negative. So again, really arguing for de-psychopathologizing gender nonconformity, that is. And again, yeah, understand that according to the DSM-5, there's still a diagnosis of gender dysphoria that may put us in a sort of a um, quandary when it comes to access to services, including potentially gender change services, kind of in the sense that we might become gatekeepers. Okay, the next slides all come from the most recent version of the W path. It's called the Standard of Care 8. So it's the 8th version. Again, it was published in 2022. And this is information that you should so the W path is something that you can download and, keep a copy and review at your or peruse at your leisure if you like, or if you want to know more about this. Certainly, if you work with this population, I would highly recommend it, and you would probably know about it already. So they use an abbreviation of transgender and gender diverse, so TGD, and they categorize it as a broad and comprehensive as possible in describing members of the many varied communities that exist globally of people with gender identities or expressions that differ from the gender socially attributed to the sex assigned to them at birth. So that's kind of again another definition. So if we use the terms transgender, gender diverse, we're talking about, again, the broad and comprehensive group of people who are not gender binary. There's other definitions according to the path that you should know, like gender nonconformity, which is again, where the person's gender expression differs from the cultural norms prescribed for the people of a particular sex. That's according to the Institute of Medicine. Gender dysphoria refers to discomfort or distress that is caused by a discrepancy between the sex assigned at birth and the person's gender identity. And of course, gender identity, again, it's a psychosocial construct, so it carries with it gender roles, societal gender roles, assigned gender roles, and of course, uh, i- in the case that in the case of gender dysphoria, on discomfort or distress associated with the primary and secondary sexual characteristics. As a reminder, primary sexual characteristics are visible and typically assigned at birth. Secondary sex characteristics happen after puberty. Um, and it's important to point out again that there's a little bit of there's still a little bit of pathologizing in that while we assume that every transgender individual has suffered from gender dysphoria, Only some gender nonconforming people experience gender dysphoria at some point in their lives. So a true diagnosis of gender dysphoria is not as common as the existence or the prevalence of gender nonconformity. Gender incongruence, of course, is recognized as a condition. Well, not of course, but it's recognized as a condition in the ICD, or the International Classification of Diseases and Related Health Problems, 11th version, or the ICD-11. I know that most of you are probably using ICD-10 still, but the rest of the world is on ICD-11. And it does contain a condition known as termed gender incongruence. Um, and again, I just figure I'd put that out there. Uh, and again, I want to emphasize, that because of stigma, many transgender or gender non-conforming, gender diverse people can experience distress or dysphoria, but it doesn't necessarily have to rise to clinically significant levels. And it can be, in many cases, it can be addressed with gender affirming options, including some that are non-medical, non-pharmaceutical, such as, again, gender terminology, the use of pronouns, the use of a name that is more congruent with their identity, or potentially simply dressing or passing um, as the other sex. Um, this is a little bit hard to see, but this is a statement of recommendations that is kind of an introduction to the W path. It says that so it's kind of their ethics, code for, per se, where they say they recommend the healthcare professionals use culturally relevant language, including terms to describe transgender and gender diverse people when applying the standards of care in different global settings. They recommend healthcare professionals use language in healthcare settings that uphold the principles of safety, dignity, and respect. We also recommend that healthcare professionals discuss with transgender and gender diverse people what language or terminology they prefer. So this is kind of their aspiration with regards to, the treatment of transgender and gender diverse people. Again, emphasizing uh, culturally sensitive knowledge and information, treatment with that upholds safety, dignity, and respect, and that incorporates the patient's autonomy and choice, or the client's autonomy and choice. Like I said, gender dysphoria is actually rare. We're on slide 309, even though this says something different, so I apologize for that. Let me fix it. Um, and basically speaks to a worldwide prevalence of about 0.01 to 0 point, I'm sorry, 0.001 to 0.003%. But I do want to emphasize that there may be some underreporting going on. They're stigmatizing, this is a stigmatizing condition in many cultures, not just our own. And so it is important to consider that this may be true underreporting. And a lot of people who are gender diverse never seek any healthcare or never really reported to anyone where this would be, where this may be a true estimate. This is one number. Estimates based on surveys, anonymous surveys, are consistent with higher numbers. So when you give the people the opportunity to anonymously report if they are gender diverse, you come up with higher numbers. It does seem to be the case that psychiatric comorbidities may be more common in female transgender individuals. And I'm not exactly sure why I have an asterisk there, but in looking at my notes, um, yeah. We'll talk about that um, in a minute, if you don't mind. I just want to make sure that I cover everything that I need to cover. So just as part of my notes, uh, again, the rates may differ based on the survey or the use of diagnostic codes versus non-pathological identification. In studies using surveys, the proportions of participant reporting gender incongruity or incongruence were somewhere between 1.1 and 4.6%. Um, and so again, it might be a little bit different. Um, that be again, the psychiatric comorbidities may be more common in male to female transgender individuals. There may So you would assume that somebody who is assigned female at birth carries the same psychiatric risk as a non-transgender woman or a woman. I mean, biological female. However, it seems to be the case that the transition from male to female, for a lot of reasons, including cultural stereotypes, and a lot of other issues that are specific to being a woman in many societies, tends to be harder. And anecdotally, it would seem that way. I don't know if you've ever had the opportunity to talk to a male to female transgender individual about their experience of recognizing, what it's like to be a woman in society, which for some people can be a rude awakening. Okay. So here's the prevalence that the WPATH reports. If you look at health systems-based studies, again, pretty small numbers, less than 1% from 0.02 to 0.1%. Survey-based studies of adults from, about half percent transgender to about 4.5 for all transgender or gender diverse. In survey-based studies of children and adolescents, the rates are anywhere from 1.2 to 2.7 transgender to 2.5 to 8.4 for all transgender and gender diverse. And I mean, I'd welcome your thoughts and comments. I've talked to folks who specialize in this population, in this field, and especially those who talk or who treat children and adolescents. My thought is adolescence is a time where a lot of identities are tried and are fluid. A lot of there's a lot of sort of searching, and that may account for the significant difference because it is quite significant, the different rates of, transgender in adolescents versus adults. So maybe something that for some folks, I'm not saying that's true of all transgender or gender diverse individuals. For some folks, it may be an identity that they try on. And then they may recognize that it's not, who they are or who they want to be, not that it's always a choice, but that again, it may be given up after some time, because of the fluidity of what happens from a developmental perspective. And that's just my opinion, again, based on conversations that I've had with people who work with this population, especially with children and adolescents. It is not, based on scientific data, so don't take my word for it. Um, okay. And again, it does not by any means negate the fact that there are some folks who know from pretty early on in childhood that there's a gender incongruence, in that that they need to address or manifest. Um, With regards to epidemiology, we know that there's a significant increase in the number of high-risk behaviors, including, leading, for example, leading to HIV infection and substance abuse. They have a higher prevalence of HIV and STDs, and certainly victimization. So whether it's partner abuse or just victimization and assault, physical and sexual assault in general. Um, of course, psychiatric comorbidities that kind of go along with that. One French study, for example, found 45% of transgender individuals in that study met criteria for major depressive disorder. 5% had GAD, 5% had PTSD. I think that's a serious under estimation. And 10% had both MDD and PTSD. Um, I, that's just one study, so I couldn't tell you if this, could be applied to all other populations of gender diverse individuals. But certainly there are significant risk from a psychiatric perspective, and also just from a health perspective. In general, sexual minority women are at increased risk for the following health conditions: tobacco and tobacco-related health problems, sexually transmitted diseases or infections, breast and gynecological cancers, obesity, heart disease, and chronic pain. Um, couldn't tell you why that is. Partly because of potentially health or risky health behaviors, lifestyle, and to some extent, again, that I don't mean to be I don't mean to stereotype, but again, we did note in the previous slide that these individuals may have a high risk of STD, HIV infection, substance abuse, drug, intravenous drug use, administration of drugs, that sort of thing. And so that may be partly related to lifestyle factors, but it also may just be a fact of the adverse childhood events and other life events that have a potential impact on health overall. The breast and gynecological cancers really cannot be could or heart disease, for example, maybe are only partly attributable to health behaviors, but they certainly can be the result of the cumulative stress associated with being a sexual minority. This is also a little bit hard to see. I'm going to try to make it bigger if I may. Let's see. So if you follow this graph, let's start with A. This is a graph from that sort of describes a minority stress model, which is a way to sort of understand why the risk of this, very serious medical and psychiatric conditions might be higher for sexual minorities. It starts with circumstances in the environment, followed by or taking into account minority status like sexual orientation, race, and ethnicity, which of course would be a another factor. We talked about intersectionality in our one of our lectures. That would be, that these is certainly a potential area where intersectionality would play a role. Um, which results in minority identity, such as gay, lesbian, bisexual. Um, but it also interacts with, so circumstances in the environment play a factor in general stressors. Um, the minority status brings up minority stress, such as, prejudice events, discrimination, violence, microaggression, actual, assault or, aggression. Minority identity may bring about additional proximal, the previous one was distal, um, proximal minority stressors, such as expectations of rejection, concealment, internalized homophobia, or internalized self-deprecating thoughts. It also may lead to, or may have an interplay with characteristics of the minority identity, its prominence, its balance, integration, and there are some contextual elements associated with that. For example, a gay, a place where there's a well-established gay community, such as, a large city. Good example would be, San Francisco, uh, versus, or New York City, Los Angeles versus a rural area in Iowa, where that minority identity is not in any way either recognized or more importantly, welcomed. And all these things combine to, impact coping and social support for both the community and individually, and ultimately mental health outcomes, be negative or positive. So I know this is kind of a convoluted graph. I try to, walk through it as best as I can. But to me, it's just a good way to understand, as we have done in other parts of the class, that interaction between the environment, and the individual, and what it means when it comes to potential health outcomes, again, both medical and psychiatric. Um, so let's talk about some psychiatric concerns. Let me make this smaller so we can actually capture it in the share screen. Um, According to NAMI, which is the National Association for the Mentally Ill, LGBTQ individuals are almost 3 times more likely than others to experience a psychiatric illness. So lots, high comorbidity, not comorbidity, because LGBTQ is not a disease or a disorder, but certainly high risk of psychiatric illness. Um, for younger, especially, pre-adolescents, adolescents, young adults, suicide is one of the leading causes of death. So suicide risk for the LGBT community is a major crisis, a major concern. Um, and something we not only need to assess for, and be very uh, attentive to, but also something that we need to, try to provide psychoeducation to both the patient and their family if possible, and to try to be good advocates to, for the prevention of. Um, LGBT youth are 4 times more likely, questioning youth are 3 times more likely to attempt suicide, experience suicidal thoughts, or engage in self-harm than straight people. Again, that's just a huge risk. And a good number, between 1/3 to 2/3 of transgender individuals report that they have at some point in their life experienced suicidal ideation. So again, once again, this is a high risk. There are also other common psychiatric concerns. Higher rates of drug use. I mentioned substance abuse, alcohol, and tobacco included, uh, uh, compared to straight people or heterosexual, gender binary individuals. 20 to 30% of LGBTQ people abuse substances, compared to only about 9% of the general population. 25% abuse alcohol, compared to only about 5 to 10% of the general population. So again, pretty high risk. Um, Again, psychiatric disorders are highly prevalent. We already said that, the rates may be 3 times higher than the general population for a lot of psychiatric disorders. Um, And in one study, oh, this is the reason that I have an asterisk. If you remember okay, so we're on slide 315, just so I don't lose my place. In um slide 309, I reported in some literature that shows that male to female transgender individuals may have more psychiatric comorbidities. So that's sexist is biological males, um, who are transgender, have a higher risk of psychological comorbidities. This report says that male sex assignment at birth was associated with decreased odds of psychiatric disorder in one study. So just one study. So keep in mind, depending on, methodology and other factors, including numbers, and the psychiatric, specifically the psychiatric disorders that they may be looking at, you might see different findings. In general, again, most of the literature points to male to female transgender individuals having more psychiatric issues. So keep that in mind. Okay, we're moving on to 316. Um, and here's some findings. Later hormone initiation and suicide attempt were associated with increased odds of substance use disorders. So, and I really hope not to get, political in any way, shape, or form, but of course, it's become this population has become a political um, target with regards to criminalization, or at least, legalization or delegalization of transgender treatments, especially for youth. So whatever your opinion may be, I just want to state the fact that deferring hormone initiation may be associated with increased use of substance use disorder. And it may, again, because the suicide risk is highest for individuals between the ages of 10 and 24, deferring treatment may also carry some risk with regards to suicide. And that's just based on the scientific findings. Um, there's also, with this population, you find increased odds of higher acuity with regards to alcohol use disorder, PTSD, and major depressive disorder. It is, uh, this is a population that may or may not seek psychiatric care. And so primary care integration would be a great avenue to be able to moderate behavioral health utilization, anxiety symptoms, and potentially to offer this individual's case management, especially for those who are seeking medical treatments, or potentially both medical and psychiatric treatments. That need to be coordinated, and where, it'd be good for the right hand to know what the left hand is doing. Um, One specific problem that is may plague this population, or maybe more prevalent in this population, is eating disorders. So as you could see, gay men, and this is, I'm giving you, just so you know, we're not talking about transgender anymore. When I talk about epidemiological issues and psychiatric conditions, I'm really talking more broadly about, sexual minorities, or, LGBTQ population, one or more specific groups. So, understand that it's not necessarily taking us out of the realm of LGBTQ issues. Is just, that we don't have a lot of data, so I'm giving you what we have. So again, gay men are 7 times more likely to report binge eating and 12 times more likely to report purging than heterosexual men. Um, Gay and bisexual boys are significantly more likely to fast, vomit, or take laxatives or diet pills to control their weight. So we know that women tend to be at higher risk of eating disorders in general, but it seems like gay and bisexual men and boys are another high risk population. There's also a report that transgender college students report experiencing disorder eating at approximately 4 times the rate of their cisgender classmates. Cisgender is a term that basically denotes somebody whose sex assigned at birth is congruent with their gender identity. So if you've seen or heard of the term cisgender, again, it essentially means um, somebody whose identity is congruent with their sex assigned at birth. Um, Moving on to 318, disproportionate number of LGBTQ youth experience housing insecurity. So that's not necessarily a psychiatric issue, but certainly an issue that denotes risk. And that could potentially carry some, some risk associated, so risk of, traumatization, victimization, um, substance abuse, and a whole host of other problems, as you could see there. Something denoted as or called survival sex, whether it is, exchanging sex for money, or even exchanging sex for food, shelter, some sort of basic need, which could lead to high risk sexual behaviors. Um, and there's a lot of issues, of course, that may lead an individual to become homeless or to experience housing insecurity. Some of it may be running away from rejecting families, and some do before even coming out. Some do because they anticipate that their family will reject them and that they will not have the opportunity or have the ability to express their gender identity in a safe way or in an accepting family or community. So they do so before coming out. They run away, leave their homes. They are also forced out by rejecting families and certainly by rejecting communities. Um, they may also age out or run away from foster care if they have experienced any abuse, either in their nuclear family or their foster family. They may become homeless because they are, either aging out or running away from that abuse. And again, with homelessness, you see high risk of mental health and substance abuse problems, including suicidal ideation or suicidal acts. You also see a great deal of academic difficulties, um, in school dropouts, or resulting from this housing and food insecurity. One estimate said that about one third of homeless youth are LGBTQ. Um, okay, so here's some numbers associated with unhoused LGBTQ youth. I think there was an article in your um, references or your, suggested readings that addressed all this. High numbers of major depressive disorder, really high numbers of PTSD, even higher numbers of suicidal ideation, almost three quarters. 57%, again, a very large number had a suicide attempt, so way beyond ideation. um, Alcohol abuse, drug abuse, including some of the harder drugs like crack cocaine, or amphetamines and cocaine or IV drugs. Um, they're also more likely to have been in a locked inpatient unit, and again, more likely to have experienced sexual victimization with a higher number of perpetrators, so not just one episode of victimization, but potentially repeated and by different perpetrators or different offenders. Um, so it's really assessment and referral is really critical when addressing a individuals who may be gender diverse. Uh, Assessing for gender dysphoria is important, because again, if it is there, if it is clinically significant, if it interferes with their ability to function, from an academic perspective, social and community support perspective, et cetera, then we do need to treat it and we need to consider it, as part of their overall treatment plan. We want to provide information regarding options. It may be, depending on your, where you come in the picture, it may be that you are, again, perceived as the gateway for whether or not this person is able to obtain gender change therapies, um, both, um, non-surgical and surgical, if that's what they want. And so we need to be, familiar with options and provide information, and certainly refer people to other sources of education and information. We also obviously need to assess, diagnose, and treat coexisting psychiatric disorders, right? Some things are going to get better just by the mere fact that people are able to express their true identity. So potentially some depression may get better, some anxiety may get better, especially if as they start to live in their desire or preferred role. And just so I want to make sure to be sensitive to the fact that saying preferred or desired sort of denotes um, the um, underlying idea that this may be a choice that they can choose to be non-transgender or cisgender versus being transgender, so that this is a lifestyle choice versus a true identity. I certainly don't mean to imply that at all. But there is obviously again something about making a choice or having the ability to live your true identity that may manifest an improvement of psychological symptoms in and of themselves. But that to whatever degree they do that, whether it is through hormone therapy or gender sex or sex change operations, surgical interventions, et cetera, will not treat PTSD. It will not treat substance abuse, and it may or may not reduce the risk of suicide. It could, it certainly does in many individuals, but you have to treat those comorbidities, or at least, think about how to address them. Again, your role may be to assess eligibility and prepare and refer for hormone therapy, assess eligibility and prepare and refer for surgery as applicable, and again, as desired or as needed. Um, and remember, just because of the risk in this population, remember what I share with you about, making it safe for people to report violence or, personal or interpersonal violence, such as do you feel safe in your, living circumstances? Have you been hit, kicked, punched, or otherwise hurt by someone else? In the past year or in the past few months. And there are multiple other ways that we can get to hopefully without putting people on guard or on the defensive, whether or not they've been a victim of interpersonal violence. Excuse me. So here's a quote, um, and it's obviously from the path, given the TGD acronym. Um, it is so for the other acronym, I need to maybe spell it out for you. GAMST is gender affirming medical and surgical treatment. Okay, so this is the position statement from the W path. The presence of psychiatric illness or mental health symptoms do not pose a barrier to gender affirming medical and surgical treatment unless the psychiatric illness or mental health symptoms affect the transgender or gender diverse person's capacity to consent to the specific treatment being requested or affect their ability to receive treatment. This is especially important because scams have been found to reduce mental health symptomatology or for TGD people. This is kind of saying saying what I sort of said before, is that in and of itself, gender affirming therapies can reduce symptoms of depression and anxiety and other, adjustment, face of life type of issues. However, more serious problems, while present, not only do we have to address them, but they don't necessarily have to stop gender affirming therapy. So we don't have to wait until somebody's clean and sober, unless their capacity to consent or their ability to take care of themselves and to receive treatment is impaired. We don't have to stop PTSD treatment. We don't have, and we wouldn't have to make that a barrier to getting gender affirming treatment. So that's the position statement of the W path, which I would agree with. In some cases, so if somebody is actively suicidal, is it, do we prioritize getting inpatient psychiatric stabilization in order to reduce the risk of suicide versus undergoing surgery? Yes, of course we would. But that doesn't mean that you put the surgery on hold indefinitely. You'd want to make it a consideration. Obviously, providing information, education, uh, in a collaborative sense, helping the patient and their family to plan for the treatments that they are seeking. So again, having psychiatric illness or receiving psychiatric treatment is not a barrier for gender affirming therapies. The other part of the position statement with regards to transgender individuals, is that because evidence suggests that hormone therapy is directly linked to decreased symptoms of depression and anxiety, the practice of withholding hormone therapy until the symptoms are treated is considered to have iatrogenic effects, so negative effects. That is when the treatment actually negatively affects the condition. If psychiatric treatment is indicated, it can be started or adjusted concurrently without discontinuing hormone therapy. Again, just a different way to say what I already said. Do not withhold treatment. They can be done concurrently, of course, with priority given to life, limb, or eyesight, as we know, but also, making sure to involve the patient in the treatment planning process. And of course, you want to maintain treatment, as in hormone therapy or any other, medical treatment that is appropriate during inpatient psychiatric care. That is, if the person is receiving, for example, rehab or again, psychiatric stabilization as a result of um, suicidal ideation or even a suicide attempt, unless it's deemed contraindicated. Um, some treatment considerations are ahead, and I have a few slides on that. So actually, let me refresh my throat here a little bit, take a little break, and that's what we're going to talk about when we come back. So again, we'll talk about treatment considerations. Let's go ahead and take a little break. All right, let's continue. Um, okay, we're on slide 323. And as I mentioned, we have about 3 slides of issues that you want to consider or that you want to think about when it comes to treatment considerations. Uh, let's talk about changes in gender expression and role. The idea of living in role, that is for individuals who potentially would like to try out or uh, um, a period of time is probably the best way to say it, in which they practice the gender expression, the ultimate goal may be gender transition, or it may not be, and maybe just living in the role of the other uh, gender. So, for example, living as a woman for a male, for a biological male, or the opposite. It may include hormone therapy to feminize or masculinize. And again, that's a choice. Any of those treatments, or all of them, maybe not all of them, but any of those treatments are potential options. And whether or not the individual chooses to pursue them, it's entirely up to them. surgery, and you might see individuals who do and do not want to incorporate parts, certain parts of this treatment plan. Sorry, it's gotten a little bit chilly here. It may include surgery to change primary or secondary sexual characteristics, including genitalia, breast, facial features such as the Adam's apple, the cheekbones, and hairline, et cetera, to including a vocal cord um, treatments. It could include psychotherapy, individual, couple, family, or group psychotherapy, depending on the situation, especially for somebody who has a partner and who's sort of married, or are committed to their partner, but they started off in a, with a different identity. And so it may be necessary to help the couple or the family to include children, not just parents, for a younger individual. It may include children, including adult children, when the person is transitioning. Um, as I mentioned before, you want to address comorbidities with potentially pharmacotherapy, and it could also include the use of psychotherapy. I talked about vocal cord changes, but also you can use voice or communication or speech therapy, and there's some speech and language pathologists sort of specialize in this type of interventions. Change in name and gender markers to include, legal changes. So a legal name change that would potentially have ramifications in terms of changing all their bank accounts, all their, properties or investments, all their, their driver's license, their, identity, any other type of identity papers such as passports, et cetera, et cetera. From a treatment perspective, it's also, make sure to address bias awareness both in ourselves and the people who comprise our practice setting. Recognizing that we are not an island. So, our receptionist, the person who makes appointments, our billing people, if we are part of a larger system, our, for example, a practice group, it may be other people who cover for you during, times when you're away, or maybe the prescriber if you're providing primarily psychotherapy, those sorts of things. So we might not just need to address the biases in our own behavior, but we may also need to find ways to, educate and provide assistance to our colleagues in how to treat this population. And that includes, what I mentioned before in the beginning, talking about having a gender affirming safe place or providing a safe place. Use an inclusive language, such as how would you like to be addressed, or even just starting as an introduction to begin with, my name is Ruth, my gender pronouns are she, her, hers. How would you like to be addressed? That's a way to normalize the fact that normalize, it's a big word, but sort of normalize the fact that you believe that there's not, the world is not just stereotypically male or female, and nothing else. This authors, Klein and Nakai, recommend that during history taking, you ask questions such as, let's review your risk factors of cervical cancers, STDs, and ovarian cancer if you're addressing a woman or a transgender female. Have you had sex with men, women, both, or neither? Again, this is a really, pretty matter-of-fact way to address, to get at whether or not somebody has risk factors for potentially risky sexual behaviors, STDs, and or in some, especially if we're talking about youth, the potential for sexual victimization. You obviously want to screen for those high risk, comorbidities that we talked about. So screening for depression, tobacco use, alcohol and substance misuse or abuse, screen for sexually transmitted diseases, protected and unprotected sexual behaviors. And the trauma history is obviously essential. So don't, um, I recommend that you don't limit your trauma history to things like, motor vehicle accidents, or, if they're a veteran military related trauma, but also, sexual trauma, domestic violence, and other forms of interpersonal violence. Um, Again, I've said this before, but treat the psychiatric conditions that render somebody vulnerable, both to victimization, but also, to suicide. Again, suicide is a very high risk with this population. So definitely want to treat. You cannot treat, how their families, how they're accepted or not accepted by their families. You can help, obviously, with family therapy if they're open to it. But you can treat depression, you can treat anxiety, you can treat PTSD, or substance abuse, or any other conditions that render somebody vulnerable to suicide, and that's a big help. It's not to say that you're responsible for preventing suicide. People have personal responsibility, but what I'm saying is we can't ignore it. And it should be a focused goal of treatment, not just the amelioration of the psychiatric condition, but the amelioration of risk factors associated with suicide. Should probably be a goal of treatment for transgender and other LGBTQ populations. You also want to discuss plans for medical treatment, surgery, and consider health behaviors, including psychological health that will improve outcomes, as well as, I would say, health behaviors that may be interfering. So if the person is actively using drugs, it's always in their best interest. Again, you don't want to delay treatment, a gender affirming treatment, but it's never a bad idea to talk to them about how to get clean and sober, how to improve health behaviors. Tobacco use is another good example. How to quit, what are some um, potential avenues, including nicotine replacement patches, or something along those lines, for making the person health, improving the health outcomes. So it's a good idea not just to improve outcomes, but to decrease, to talk about health behaviors that would decrease morbidity and mortality. Um, uh, there's no data on potential impact of psychotropic use on hormonal therapies. So in general, so from a pharmacotherapeutic perspective, you can prescribe anything. And the choice of medication should be based on their symptoms, the potential side effects that you want to address or avoid, the potential side effects that you want to avoid, and or the symptoms that could be potentially um, treated with some of the side effects of the medication. So, for somebody who has severe anorexia, for example, as in, uh, you know, maybe that's not the right word. They have, decreased appetite. They're underweight. Um, you might want to consider a medication that would improve their appetite, such as an NDRI or mirtazapine, um, uh, for the treatment of depression or anxiety. Whereas, for somebody else, you would just, potentially start with an SSRI. So again, the choice of medication, the choice of pharmaceutical agents has more to do with what is their psychiatric condition that you're trying to treat, the side effects that you want to avoid, or the symptoms that you might want to address with the use of a specific medication, as opposed to anything that would interfere with hormone therapy, because there's no data on that. And as I mentioned before, uh, you would not expect that there would be any contraindication. Um, I figure I would include some information about transgender and sexual minorities in the military, just because that is my area of expertise. And that is an area that has potentially had a sway in how other parts of society integrate, sexual minorities, and also, there's some potential impact there. If you work with the veteran population, or, again, just from a government perspective, this is an important area of consideration. Obviously, transgender and sexual minority policies can change. I mean, you can get whiplash at during the last Trump administration at the touch of a tweet. Um, and so, but even historically, don't ask, don't tell policies that were established by Congress during the Clinton administration, they had significant impact on, LGBTQ and sexual minorities. Yeah. And they still showed some stereotypical bias. So, for example, during Don't Ask, Don't Tell, women represented 30% of the discharges, but at the time, they only comprised 14% of the force. So wouldn't you know it, more women were discharged because of homosexual activity or homosexual behavior compared to men. Uh, I want to say go figure, but you may or may not like my expression. That's just what I'm going to go with. Again, you could see sexual or sex-based bias even in that. Is there more acceptance? In the, for sexual minorities in the military, there is some belief that gay women are more likely to serve than gay men. So 10%, 10.7% of women in the military consider themselves gay versus only 4.2% in the civilian population. And if you're old enough, there are some um, there is some stigma associated with that. I don't know if I mentioned this in, in previous classes, but I now work with veterans. I used to work with active duty. Now I work with veterans. And you hear the stories, and some people have a very colorful way of saying that. But, if you were a woman who voluntarily enlisted in the 60s or the 70s, there was an assumption that you were either gay or lesbian, and or you are quote unquote a whore, is what a veteran told me, female veteran, by the way. There is some stigma, there may be some stigma associated with being uh uh, at least, in the past and previous decades, a woman and women serving in the military, but there perhaps is more acceptance in that, some of the jobs in the military, all of the jobs in the military now are gender neutral, in that there are women and men have the same expectations for behavior. There's also equal pay, not behavior per se, but job performance, etc. There's also equal pay. You could argue potential equality with regards to promotion opportunities, although that's something to be said. I think that's something to be determined. Let me just put it that way. But there are some ways in which the military may be a more welcoming community for sexual minorities, and specifically for gay women. Um, okay. There's also some barriers to care. For example, bisexual women are more likely than other sexual minorities to delay or not access health care in the military. Maybe it's still, there's still some bias or lack of acceptance with regards to bisexuality. Bisexual women also tend to have more depression, anxiety, suicidal ideation, poor general health, eating disorders, and experiences of physical and sexual abuse as compared to lesbian women or gay women. Treatment, from a treatment consideration, more sexual minority veterans and service members report suicidal ideation compared to their heterosexual counterparts. It's just like in the civilian population, there is higher incidence of suicidality. And there's also, medical stigma still. I have to say, I did encounter some, physicians or healthcare providers who just did not feel comfortable treating sexual minorities and who would refuse, for example, to initiate hormone therapy, or even refer someone for hormone therapy, um, in the military. Or to talk about, ask questions like, are you having sex with people who are male, female, or both? Okay, I realize that's not a lot. We, spent just barely over an hour talking about, sexual minorities and transgender issues. There's plenty more where that came from. I think that what I mostly want to emphasize is the idea that from a psychopharmacological perspective, or from a, pharmacotherapeutic perspective, the reason that you don't have slides that talk about, treatment guidelines for how to treat depression, how to treat anxiety, how to treat, other psychiatric conditions, or even how to treat gender dysphoria. Again, the incidence of gender dysphoria is very low. Um, we don't, if there is a major depressive episode, you'd want to treat it like a major depressive episode. But in general, gender dysphoria is treated with gender affirming therapies, and can certainly benefit from that alone without any psychotropic medication use. But again, as for any other conditions, including some of the ones that this population is most at risk, like substance abuse and PTSD, depression and anxiety, you would treat it just like you treat any other individual. You just, my recommendation is that you provide a gender affirming, safe space, where this individuals can share with you their experiences so that you can treat them appropriately. Okay, let's talk about men's issues. And again, relatively, this is a very small part of our presentation. Um, in this class, but we're going to talk about this. We're going to talk about male epidemiological issues, so issues that are more prevalent in men versus women. We're going to talk about how to treat those conditions, psychiatric conditions specifically, that are more prevalent in males. We'll talk about sexual dysfunction. We'll talk about the concept of adrenopause, which is some people have equated to menopause, and a very specific male condition, which is prostate cancer and other issues associated with prostate health. That's in a nutshell, what we will be able to cover in this discussion. So, this is a little bit dated now, but we've seen in previous sections of the class, main causes of death in males are different than women, and the biggest differences are highlighted on this slide. The rate of unintentional injuries or accidents, the prevalence of suicide, as in death by suicide, not suicide attempts or suicidal ideation, and the incidence of chronic liver disease and cirrhosis. I think I mentioned, I I don't have a slide on it, but we've talked about it in previous lectures. The incidence of homicide in certain subgroups of males, so Black males, in American Indians and Latinos, um, also show homicide in the top 10, which is not something that we see in women. For cancer specifically, the top sites of cancer are, gender specific too. Prostate being the number one, breast cancer being number one in women. And so cancer does tend to, or the, common sites of cancer tend to be sex specific. The lung and bronchus being the second one, which is likely more related to lifestyle factors, and then colon and rectum being the third most common. There are other common sites of cancer in men: urinary, bladder, the skin, non-Hodgkin lymphoma, kidney, oral cavity, and pharynx, leukemia, and pancreas in that order. Um, As in, with regards to sex-specific disorders in men, and main causes of illness, so this is morbidity, non-mortality, prostate problems, liver disease, high blood pressure or hypertension, cluster headaches. Remember, I asked you what type of headaches are more common in men versus women. And we talked about cluster headaches. So, migraines and tension headaches being more common or more prevalent in women. The cluster headaches is the exception. Chronic bronchitis and COPD, again, likely related to lifestyle factors and, a gender or sex specific condition, just like prostate, hypogonadism, or low testosterone levels. In hypogonadism, I'll just make a segue here to say that this is something that you will see in clinical practice because there's a lot of psychiatric symptoms that are associated with low testosterone levels, and also that may be ameliorated when the hypogonadism is addressed. So I'll talk about it later, but I do want to make sure to underscore the idea that sometimes that again we could see psychiatric illness, depression, anxiety, anhedonia, um, associated with low testosterone that could be ameliorated just with hormonal replacement and may or may not need psychotropic use or psychotherapy use. Here's some psychiatric disorders that are more prevalent in men. We covered some of these before, in previous graphs. But substance use disorders, certainly more prevalent in men, compared to women. Antisocial personality, more common in men. Conduct disorder, compulsive gambling, compulsive sexual behaviors, intermittent explosive disorders. I know that they have a different name in DSM-5. It's not a common diagnosis, so I don't remember that right off the top of my head. But I think you know what I'm talking about. Muscle dysmorphia, and steroid abuse, as well as suicide. And again, I mean suicide attempts and death. I mean death by suicide, not suicidal ideation. Um, so, for example, alcohol use disorder is more than twice as common in men versus women. Um, and antisocial personality, men are 3 times more likely to be diagnosed versus women. Okay. We talked about differential rates of eating disorders in men versus women, and with men kind of being the exception. But I don't think it's good for us to ignore the risk of eating disorders. That's why in men, that's why I want to talk about them, kind of carve out some time to talk about this condition, because it can definitely lead to negative health outcomes, as well as increased suicidal risk. Um, Many people assume that males don't carry risk of eating disorders. Typically, they are diagnosed later in life, so they may not be as uh, likely to develop an eating disorder in early adolescence, uh, as women typically do. Um, but um, but it can certainly there can definitely be a risk. So it's specifically because of the risk of dying from the condition. You could see males represent 25% of individuals with anorexia, and they are at higher risk of dying from the disease or complications from the disease. So again, higher risk in terms of the severity of the illness. Subclinical eating disorder behaviors, including binge eating, purging, laxative abuse, and fasting for weight loss, are nearly as common among males and females. So that's maybe a surprise to some of us. Um, it's also, something that is not as widely recognized as perhaps it should be in athletes. And although most athletes with eating disorders are female, male athletes are also at high risk, especially those that are competing in sports that emphasize diet, appearance, size, and weight, such as wrestling, rowing, horse racing, and aesthetic sports such as bodybuilding, gymnastics, swimming, diving, skating, especially figure skating, and that sort of thing. About 33%, by some estimates, about 33% of male athletes in this sports may be affected by disordered eating. Um, and again, I don't know how common that is, but I, had a friend and who was in a wrestling team in high school and college, and he shared how because you have to remain in your weight category, especially in when you're getting close to a competition. There's disorder eating going on. You may either binge the day before a competition, or you may starve yourself days before a competition in order to maintain again your weight category, which essentially uh, is a disordered eating in practice. Um, Specifically for military members, bulimia nervosa is the most common type of eating disorder, but it is also common to see in men, specifically body dysmorphic disorder, affecting about 1 to 3% of the overall population. Uh, in comparison, 13% of male military members and 21% of female military members. Those are huge numbers. You may or may not know this, but the military has weight standards. And so having disordered eating, once again, kind of like my wrestling anatomy analogy, military members who binge or starve. Uh, Binging is not as common before the physical fitness exams, but certainly starving or going or using laxatives or other compensatory mechanisms, extreme dieting before physical fitness tests are due or scheduled is actually something that you hear a lot about in military members. And that, may be episodic, happen one time a year, a couple times a year, depending on how often they are tested. And also depending on whether or not they have had a failure before, or it may be the precursor to an eating disorder because then it becomes a pattern. Having been a military member myself, I know that, there's a period of time before every physical fitness test in which you just kind of watch what you eat and you're more careful about making good choices if you want to make your weight. However, again, that can become very extreme for some people. Um, So in terms of treatment considerations, again, I don't, there's not any clinical practice guidelines that would say treatment with this dosage of this medication versus, how you would treat a woman. From a biological perspective, keep in mind everything that we talked about, including, genetic polymorphisms and, cultural or ethnic variations and that sort of thing. But there are some things that are important to keep in mind just based on the differential, prevalence of certain conditions. So, for one example is the use of anti-craving medications such as naltrexone for substance abuse treatment and also for impulse control disorder, including porn addiction, sex addiction. I realize porn addiction is not a DSM condition. But some men do seek treatment for, again, compulsive sexual behaviors, which is really what porn addiction may be, especially if it interferes with activities of daily living or quality of life, including relationships, such as they're spending a great deal of time involved in that activity as opposed to, other important areas of their life. And so that might be something that you would consider. Naltrexone, again, being something that somewhat of an anti-craving medication that affects the dopamine uh, the pleasure pathways of the brain in some way, may be a good alternative for somebody who wants to consider pharmacotherapeutic interventions. Obviously, this would all be not FDA approved. That's not, what this medications were designed for. But with care and with providing the appropriate informed consent, it may be an option for some individuals. You might consider the use of clonidine, propranolol, and even Lamictal or lamotrigine for intermittent explosive disorder, impulse control behaviors for severe anger that may be part of that intermittent explosive disorder picture. And that again, it's clinically significant and affects other significant areas, affects other important areas of their lives. Again, all non in the FDA approved. You can also consider the use of SSRIs for compulsive sexual behavior. Again, this is a good example of using the side effect of a medication to actually be to provide a therapeutic effect. So, by compulsive sexual behavior, excessive masturbating or, other sexual compulsions that you might that the person is interested in potentially inhibiting. Again, having the SSRIs diminish sexual interest and potentially provide a little bit or provide some, not a little bit, but maybe leading to sexual dysfunction. Maybe a way of tempering some of those behaviors. Again, um, it is not an FDA approved use, so you'd have to use it with their consent. And then you want to consider pharmacological treatments and their impact on suicide risk. Again, black box warning on a lot of psychotropic medications, especially the antidepressants, with regards to suicide risk. And one of the things they mention is males under the age of 25 seem to be the highest risk group. So if you're starting a psychotropic medication for men, I'd say men any age, but certainly men in this age category, you have to provide informed consent and you have to monitor closely and you have to assess and reassess the risk as you make treatment transition. So when you're titrating the medication, when you're making a change in the medication regimen, or when you're tapering off the medication, those are all times that you should be monitoring for suicide risk because they can certainly experience, either an exacerbation of suicidality or new onset of suicidality associated with medication use. Okay. Next, we're going to talk about adrenopause, and this is certainly an area that is not well studied. So I'm kind of leery to talk about this, but somebody suggested this is an important topic. At one point, this is something that was suggested to me as something of an important topic for us to discuss. So, at the very least, I want to give you some idea of what it is and what if you're interested in getting more information, there are some resources. You could use PubMed or other resources to get additional information. So again, not a widely known or commonly known condition, but it's understood to be an age-related partial insufficiency of the adrenal cortex, kind of like, again, sort of equivalent to menopause. And what it's characterized, well, I mean, it's thought to have to be associated with the hypothalamic pituitary adrenal axis activity that leads to reduction in DHEA and its sulfate DHEAS, as well as adrenocorticotropic hormone or ACTH and cortisol production. Um, remaining unchanged. So you see the reduction in DHEA and DHEAS, while ACTH and cortisol remains relatively unchanged. This decline in this biological activity, referred to adrenopause, may contribute to what would be described as the physiology of human aging. Um, let's see, what and by the way, DHEA is a precursor of the sex hormones. And so basically we're talking about a hormonal reduction. This reduction in hormonal production or DHEA levels has been correlated with some health problems. This steroids seem to play a role in the maintenance of immunity, musculoskeletal integrity, and cardiovascular health. Age-associated declines in adrenal androgen production may lead to decreased immune function, osteoporosis, and atherosclerosis, or the thickening or blockage or the veins. Um, and so there may be some health related problems associated with that. Um, Findings with regards to DHEA supplementation or administration in patients with adrenal insufficient are not are mixed. Um, it doesn't seem that, with DHEA supplementation in adrenal, that means normal, patients with normal adrenal function, is useful. Um, and studies assessing action on sexual function, metabolism, and cardiovascular functions have provided conflicting results. um, Herbal supplementation hasn't proved safe or effective for aging related low testosterone, and perhaps some of them might even be dangerous. And I think there's some indication that long-term use of DHA or DHEA supplements may increase risk of prostate cancer. Um, let's see. Part of I don't know if I talk about it later. I think I do talk about it later. So let me hold off on comments with regards to low testosterone. Here's an example. Pope et al. In an 8-week randomized placebo-controlled trial administered a testosterone transdermal gel to men between the ages of 30 to 65 who had refractory depression and low or borderline, so low testosterone or borderline testosterone levels. And what they found is that subjects who received testosterone gel versus placebo reported improvement in scores on the Hamilton Depression Rating Scale, um, and greater improvement compared to the placebo group. So there's some indication that, for maybe not some of those, physical medical changes, but, for refractory depression, there may be some helpfulness, perhaps, to using testosterone replacement. But there are risks associated with that treatment, so just kind of be mindful of that. Um, There's adrenopause or andropause, is another term that you might use. It's essentially the decreasing testosterone levels or a reduction in the bioavailability of testosterone that is related to aging. So it's a normal a part of aging, not pathology. Um, and it has been referred to as late onset hypogonadism. This male menopause, again, is poorly understood in research, so I think we need better definitions to be able to talk about this. Um, and it's not an issue that it's on the minds of physicians, to be honest with you. Most physicians have never drawn a testosterone level on men, and they wouldn't they wouldn't think about necessarily drawing a testosterone level, for somebody who presents with a, clinical presentation of anergia or depression, or even potentially some of the other characteristics of decreasing hormonal levels. Um, and this is what I was going to bring up before. The other issue is that there is no clear delineation of what a normal testosterone level is for the same male at age 25 versus 45 versus 65, or even for different males. I don't think I have it, but the normal range of testosterone levels is pretty wide. And there are no correlates between somebody who is normally, quote unquote, meaning that's their typical, um, at the lower end of the range. There are no correlates with, for example, sexual dysfunction or, characteristic male or typical male characteristics, or, energy, motivation, muscle strength, any of those things, versus somebody who is typically or normally at the high end of the range. So somebody could be, uh, um, can have, uh, quote unquote, relatively low levels of testosterone that still are in the normal range, and have no complaints with regards to some of the, issues that we're talking about here. And likewise, so we're talking about different males, with the same level of functioning may show different levels of testosterone. The same male, may have different levels of testosterone at age 25 versus 45 versus 65, just as an example, but they don't necessarily show differences in function, again, sexual function in other areas that, may be affected by testosterone levels, such as muscle endurance and muscle strength. They may not see those changes associated with variable hormone levels. Um, However, low testosterone can manifest in changes in sexual function, as I mentioned before, changes in sleep patterns, physical changes, and emotional changes. And so this is a good time to talk about hypogonadism, or low testosterone levels. Um, when you have an individual that has been diagnosed or is presenting with hypogonadism, you may see some psychiatric issues. For example, again, decreased libido, which may be a manifestation of depression, but it may be just decreased adrenal function. Even for example, showing fewer spontaneous erections, such as during sleep, or, at the extreme, infertility. You may see insomnia or hypersomnia, increased fatigue. You may see increased body fat, so kind of a, especially around the middle, reduced muscle bulk and strength, decreased bone density, swollen or tender breast or gynecomastia, loss of body hair. Rarely, very rarely, again, only in the most severe cases, you might see hot flashes. You might also see decrease in motivation, self-confidence, feeling sad, depressed, or even anxious, and trouble concentrating or memory lapses. So you could see, if we just look at this, again, hypogonadism, whether it's related to another condition or adrenopause, um, there's a significant overlap with symptoms of depression. And so it is important to ascertain if this is a comorbid condition, or something that needs to be addressed. Um, sorry, I need to plug my computer. Um, as the, primary cause of their, psychiatric symptomatology. And I have seen it both ways. As a matter of fact, because of my experience with military members, it is not uncommon to develop hypogonadism as a result of a traumatic brain injury. So whenever I have a combat veteran or somebody who has experience in non-combat traumatic brain injury, presenting with symptoms of depression, I will draw or ordered to be drawn rather a testosterone level, because if we're dealing with hypogonadism associated with TBI, then we might have another condition that we need to treat. Um, okay, so this again, I really want to emphasize this because of its potential clinical implications when it comes to the treatment of males in your practice. Uh, okay, so I again, treatment if it's needed, it's controversial. Studies on this slide, 345. You see 9 studies evaluated the effects of work on andropause symptoms. 8 studies examined its effects on age at menopause onset. And 9 studies address its effects on menopausal symptoms. So keep in mind, why are we talking about menopause? Because women have testosterone too. So we're talking about the decrease in testosterone levels. And you could see their results there. Um, Work-related factors such as psychological stress, physical effort, sleep disorders showed a significant correlation with andropause manifestations. So it may be, again, just age-related changes in, um, productivity, efficiency, those sort of things, as well as, the emotional uh, ramifications of that. Um, is there a relationship to depression? So in a study with 521, and I quote old men because that's how they describe them. They
The
uh
observed difference between adults aged 18.
sorry, Siri decided that she wanted to contribute. Um, so as I was saying, old men is how the study described uh this individuals, and I really don't have, I have the link to the study, but I don't remember right off the top of my head what that age, how that was defined. 51% of the study population had clinical symptoms of androgen disorder, and about 4% of them had severe symptoms, and there was a strong correlation between the AMS score, which is the Aging Male Symptom Scale, so the symptoms associated with androgen disorder, and depression. So there is a correlation, just like with menopause, there is a correlation between andropause and symptoms of depression. Um, Diabetes, cigarette smoking, depression, and spousal age also had significant associations. So it is not very clear cut. With regards to late onset hypogonadism, there was a study in Japan that looked at androgen replacement therapy. And they found, improvements in physical symptoms in the SF36 health survey. They found decreases in waist circumference and serum triglycerides, whole body and leg muscle mass volume were increased. There was increase in serum hemoglobin, sorry, and no difference in side effects between placebo and ARD group. So relatively safe, excuse me, with regards to side effects. I don't know the length of the study, and I don't know if it has been replicated, to be honest with you. So just keep that in mind. So in general, when it comes to androgen replacement therapy or testosterone replacement therapy, more studies are needed, right? Um, it is, to assess the long-term efficacy and safety of combined hormone replacement therapy in older men before this becomes a general practice. Um, and that's a quote. By the way, it talks about prescribing hormone replacement therapy for combating the sarcopenia of aging. Sarcopenia is a syndrome that basically relates to progressive and generalized loss of skeletal mass, muscle mass, and strength. Um, and again, this just part of the normal human aging process. Okay, let's talk about to use our last break. But before that, let's talk about the prostate. Um, Another very specific sex specific condition. And let me start off. You may have covered it in other classes, so this may be some repetition here. Um, as you know, the most common prostate issue is benign prostatic hyperplasia or enlarged prostate gland. That can cause really bothersome urinary symptoms, and it's pretty common in aging males. Starting, potentially in the mid 40s, maybe later for some folks. Um, and causes, frequent urination. If untreated, BPH can block the flow of urine and out of the bladder and can cause bladder, urinary tract, or kidney problems. So it certainly can be not benign, again, especially left untreated. Um, Here are some symptoms associated with BPH. You might have the increased frequency or desire to urinate, but a weak urine stream, difficulty starting the urination, straining, not being able to completely empty the bladder, which leads to increased frequency. UTIs or urinary tract infections, formation of stones in the bladder. Um, and a whole lot of, other symptoms. I talked about frequent or urgent need to urinate. This may be one of the symptoms, may be that the individual feels like they have to go and they have to go now. Again, increased frequency of urination leading to nocturia, which is nighttime urination, with some patients, especially older patients, complaining of getting up multiple times during the night, which can reduce their sleep quantity certainly, but quality as well, and reduce kidney function. There are some risk factors associated with BPH, including aging. So again, some symptoms rarely um, uh, happen before the age of 40. But by about 55 years of age, about 1 in 4 men have some signs and symptoms. And by 75, about half of all men experience BPH. Um, Family history is contributory, so may, also predict, who may experience BPH, and also where you're from. It looks like there are some biological predeterminates, such as that it's more common in American and Australian men, as an example, less common in Chinese, Indian, and Japanese men. There may be some environmental factors associated with this. I really don't know, but that is a finding. And of course, besides BPH, men can also experience prostate cancer. Prostate cancer is one of the most common types of cancer in men. Again, the equivalent would be breast cancer, which is the most common type of cancer in women, in terms of the equivalent as being a sex-specific type of cancer. Um, Usually it grows slowly and initially remains confined to the prostate, but it may cause serious harm, and it certainly may spread. So early detection is important. Cancer screening, like um, um, prostate exam, and or laboratory tests are useful and highly recommended for men over a certain age. I believe prostate screening start at age 40. Don't quote me, may be wrong. But certainly if you have a history, or if your patient has his family history of prostate cancer or even benign prostatic um, hyperplasia, you might want to recommend that they start screening earlier. Or they talk about with their PCPs about screening. It may come with the same symptoms associated with BPH. It's important to recognize those symptoms that would become a red flag, such as blood in the urine, blood in the semen, swelling in the legs, discomfort in the pelvic area, and bone pain. Those are things that you wouldn't see bone pain, swelling, or blood in the urine or semen associated with BPH. So that would be a clear indication that additional screening evaluation is needed because BPH it would not be the causal factor. So maybe it may be um, maybe a tumor. Um, some risk factors associated with prostate cancer include older age, again, more common in older males, most common in overall in men over the age of 65. Being Black is a risk factor for prostate cancer, so this taps into both a um, just kind of FYI, but also a culture or ethnic consideration. It's also more likely to be aggressive or more likely to be an aggressive type of cancer or more advanced at um, diagnosis. That kind of brings up issues with related to screening and preventative type of care. Family history, I mentioned before. Obesity is also a risk factor associated with cancer of the prostate. Um, it also, may have more advanced cancer at diagnosis, and also a cancer that is more difficult to treat. Complications of cancer in the prostate include spreading. Like I said, it's usually confined to the prostate, but it can certainly spread to other areas. It may lead to incontinence, which can be the result of the condition, the cancer, or its treatment, the chemotherapy, or other types of treatment. May lead to erectile dysfunction or ED, which can also be the result of prostate cancer or the treatment. And also, treatment including surgery, radiation, hormonal treatments. This is what I was talking about, the PSA test, prostate specific antigen. I was thinking PSA, and then so for somehow in my mind, I got stuck with public service announcement. So prostate specific antigen is a blood test that can be given relatively easily, non-invasively to men over a certain age. Again, I want to say the recommended age is 40, but certainly for individuals who have a family history of prostate cancer, I would recommend that this test be given at an earlier age. And then, of course, digital rectal exam is the prostate exam that I was talking about before. That is standard practice screening preventative care for males after a certain age. Um, okay, that is all, and that marks the end of our second hour. When we come back, we'll talk about male sexual dysfunction, and then briefly, we're going to talk about infertility and just close with a brief discussion about interpersonal violence, which is another sex um, related topic. Okay, so let's take a brief break and we'll be back shortly. All right, guys, true home stretch. We're in the last section, last segment today. We're briefly going to talk about male sexual dysfunction, as I mentioned before. This is an important topic, both in psychiatry in general, but also because of its association with psychotropic medication use. And then we're going to talk about additional gender or sex issues, as I mentioned before, infertility, and potentially, at least briefly, interpersonal or gender sex specific violence. I do want to start with the poll question. So let me see if I can. Okay, I did paste it. Okay, it's on the chat. But because of any issues associated with the recording, I'll go ahead and read it. It says, due to a significantly higher risk of suicide among transgender individuals, a prudent medical psychologist would be wise to do the following when treating a depressed transgender patient. A, avoid treatment with SSRIs. B, fully assess for suicide risk and protective factors and establish a safety plan if needed. C, start at the lowest dose level and monitor frequently and closely for development of suicidal ideation. D, aggressive titration to standard dose, as in the sooner you treat the depression, the better. And E, B, and C are correct. The correct answer is B and C. So you want to fully assess for suicide risk and establish a treatment safety plan. And you want to start at the lowest level and monitor frequently and closely for development of suicidal ideation or suicidal crisis. Okay, so let's put the chat aside for a moment um, and talk about male sexual dysfunction. Okay. So just like with women, we have sexual arousal disorders. We also have a few other types of disorders associated with sexual dysfunction, priapism, gynecomastia, and premature ejaculation. You've heard of priapism as in its association with trazodone. I believe also quetiapine, if I'm not mistaken, is another agent that you may have heard of with that association. Gynecomastia is development of breast tissue, including breast tenderness in males, and potentially even growth of sexual tissue. And then, of course, premature ejaculation is exactly what that entails. In the sexual arousal disorders, we have, decreased libido or sexual interest. We also have the potential for erectile dysfunction or ED, which is very common commonly known. It's not very common, but it's commonly known, probably the most common of the male sexual disorders. Um, so let's talk about decreased libido. Sexual arousal disorder may be a symptom or a symptom of another condition or a consequence of sexual disorders or sexual dysfunction associated with antidepressant treatment from a psychological perspective. There may be other causes of decreased libido that are medical. And so just I'm not discounting other potential medical etiologies that need to be addressed, and certainly recommend that they are addressed. But certainly, they're, from a psychiatric perspective, commonly symptom of depression or another mental health condition, or maybe the result of treatment. Um, Erectile dysfunctions, or erectile dysfunction is relatively common. Um, Approximately 18 million men have partial or complete ED. Up to 50% of the male population have experienced some degree of erectile dysfunction that may be occasional, once, or repeated chronic, that sort of thing. So it may range from episodic or situational to, a very chronic condition. And in terms of, prevalence in the healthcare system, about one estimate is that about 1 in 10 males between the ages of 18 and 59 saw a physician with concerns about ED. So this is not an old man's problem, I guess, necessarily, as you could see, as there's some indication that this may be a problem in otherwise healthy young males as well. Um, this estimate is a little dated. I don't know if I have the date right here. I do believe that with the sorry, sorry, my phone is acting out again. Um, with the increased um, um, accessibility of telehealth, and drugs by mail, essentially, you see a lot of commercials on TV for him, and other, yeah, less potentially less stigmatizing ways in which people can seek help for sexual dysfunction, that there might actually be a higher prevalence than that. So this is, again, this is a little bit dated, certainly more uh, 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 prescribed to a time where you actually had to see a physician in person for a complaint like this, and the estimates may be the prevalence may be underestimated if we take into account the people who, may use again telehealth or other, um, perhaps a little bit more um, less stigmatizing ways of seeking help. There are some risk factors associated with ED, and of course, I'm going to talk about it. I'm going to talk about ED quite a bit because it is the most common sexual dysfunction. Heart disease, including clogged blood vessels or atherosclerosis, high cholesterol, high blood pressure, diabetes, obesity, anything that is part of a metabolic syndrome, and metabolic syndrome itself, a condition involving high blood pressure, high insulin levels, fatty fat around the waist, fatty liver, not listed there, but certainly part of it, and high cholesterol. So all of these things are associated with not just cardiovascular risk, but certainly a common cause of ED. Other causes include Parkinson's disease, multiple sclerosis or MS, low testosterone levels. We already talked about hypogonadism, whether it's acquired or um, age-related, and or, perhaps, from other etiologies. Something called Peyronie's disease, which is development of scarred tissue inside the penis, and tobacco use are other causes of ED. Certainly other substances, including alcohol use and other drugs of abuse. The treatment, as I mentioned before, prostate cancer or enlarged prostate or BPH, surgeries or injuries that affect the pelvic area or the spinal cord, and certain prescription medications, including psychotropic medications, as we mentioned before. There may be some psychological or behavioral causes of ED. Those include depression, anxiety, and other mental health conditions, including, just stress, life stress, relationship problems due to stress, poor communication, and other concerns. Sorry, I just want to make sure my earbuds are working. Um, Drug abuse, alcohol use disorder, I mentioned already. Um, there certainly may be psychological or behavioral etiologies for this condition. Besides the psychotropic medications, there's other pharmacological agents that are associated with ED, including antihypertensive, anticholinergics, disulfiram or anabuse, estrogen therapies, nicotine. Um, I've already mentioned the psychotropics and drugs of abuse. Okay, so treatment of ED is the PDE5 inhibitors, which I'm sure you guys talked about in other classes. Some examples there include Viagra, the little blue pill, Levitra, which is a longer acting prescription or, yeah, formulation similar to Viagra, Cialis. And essentially all of these medications work in the same way. The mechanism of action is listed there. They increase blood flow to the penis, which allow a man to get an erection in response to sexual stimulation. So the variation in these medications is dosage and how long they work, as well as their side effects. But in essence, they're all the PDE5 inhibitors have the same mechanism of action. Um, Possible side effects of the PDE5s include uh, flushing, nasal congestion, headache, visual changes, and stomach upset. There's other treatment options besides the PDE5, although again, those are or the PDE5 inhibitors. They are the first line treatment, as I mentioned. But there are other treatment options listed there, including self-injections, suppositories, testosterone replacement therapy, penis pumps, implants, as well as surgery, and of course, psychosexual therapy, if the um, ED is related to psychosocial or psychological factors, and certainly if it has uh, permeated or if it's manifested in terms of issues such as performance anxiety or couples issues or communication issues. Okay. Priapism is as again, you've heard in other classes, an erection that lasts for a prolonged period of time. It's an undesirable side effect of the use of certain psychotropic medications, but it can also happen for other reasons or with other causes, and it may require surgical intervention. So it's a serious issue, and whenever you talk about side effects, potential side effects of medications with patients, and you bring this up, they may think it's a desirable side effect, but it is not. Anything that requires surgical intervention of the reproductive organs um, is not something to play with. Um, it Again, there's gynecomastia, which may also be related to the use of psychotropic medications. Most likely, the antipsychotics, the drugs that both fall in the category of first generation and second generation antipsychotics, can cause gynecomastia. They also may be Gynecomastia may also be related to steroid or steroid use. And there are some other possible causes. But of course, we bring it up in light of some of the medications that we prescribe. And then there's premature ejaculation, a condition that we may actually be able to treat with either PRN or continuous use of a low dose antidepressant, such as sertraline or paroxetine. Again, this is another good example of using the side effects of the medication in order to treat a symptom. So just like you would treat hypophagia with mirtazapine, you might treat premature ejaculation with medications that are known to cause delayed ejaculation, and therefore may bring about normal, quote unquote, sexual functioning. Um, this is an off-label use, and of course, it is important that you document it appropriately. I'm reminded of a case where, somebody, every now and then, in the context of military service, we have to assess based on a health record review whether somebody's fit for duty, especially what we call special duties such as flying, dealing with nukes, and that sort of thing. And there was a notation in the record that somebody had made about an individual who was using an SSRI, but there was no psychiatric diagnosis. And so, the question that was brought to me as a provider and that had to sign off on the record review is, why is this person on antidepressants if they're not depressed? And, sure enough, if you look closely at the record, the prescription was associated with treatment of PE, or premature ejaculation, which is, again, off-label, but an appropriate use. Um, so for antidepressant-induced sexual dysfunction, I think it would be true of antipsychotic-induced sexual dysfunction, because that does happen too. What you need to recognize is that in general, we are talking about sexual dysfunction, not just decreased sexual interest. So it might translate into decreased libido, but generally speaking, it is a sexual dysfunction that manifests in decreased sexual interest. So, what men experience, whereas women typically experience anorgasmia, or delay in achieving orgasm, men can experience erectile dysfunction, or difficulty achieving or sustaining an erection. Um, they may experience ejaculatory disturbance, usually manifested as delayed ejaculation or delayed orgasm. In those situations, you would want to consider alternatives, such as switching to another, agent that has less potential for sexual side effects. Uh, or you can use bupropion alone or in combination. And one of the things that, I don't know if I mentioned it before, but one of the things that you should know about the use of bupropion for dealing with uh, antidepressant-induced sexual dysfunction is that you can use it PRN. So you don't have to dose it continuously. Um, it can be episodic use, and what I tell patients is, if you can sort of anticipate or plan, it does, take away some spontaneity, but if you can anticipate or plan times when you're going, or days when you're going to have when you're going to engage in sexual activity, then use the bupropion on those days. In this case, if we are using it merely for the treatment of sexual dysfunction, I would also recommend the immediate release formulation, as opposed to the extended release formulation of bupropion, because the effect is much more quick. And so again, if you can, sort of predict within hours engaging in sexual activity, then you can use a medication, just a short amount of time before that happens. The caveat with bupropion is, especially with immediate release, is that it can affect the sleep quality. And so, you definitely just want to inform the patient that they might experience some difficulty sleeping um, in that situation. You might also consider a switch to venlafaxine or mirtazapine, which are also depressants that are associated with um, um, a decreased risk of sexual side effects. So I know that was very quick, but that's all I'm going to say about sexual dysfunction, or uh, male sexual dysfunction. And we're going to move on to slide 367 and talk about some additional gender sex issues, including infertility, which is kind of a big one. I bring it up in this context because we talked a lot about reproduction, or the reproductive system, and, pregnancy, which is the opposite of infertility. That would be fertility. And for, individuals who want to have children, it's quite a blessing. For those who want to have children, infertility is definitely a curse, and a significant issue when it comes to psychiatric problems. So again, let's start with some definitions. Infertility means not being able to conceive or get pregnant after 1 year of trying. So it's not just once or a few times, but really concerted efforts to conceive. 6 months is the definition for a woman over the age of 35 because conception is a little bit more difficult at what they call advanced maternal age, meaning 35 or older. Um, People who can get pregnant, so they can conceive, but they cannot maintain a pregnancy. That is, they have experienced one or more miscarriages, are also potentially infertile. Um, for pregnancy to occur, we talk about this before in the context of preventing pregnancy. You have to have ovulation, you have to have fertilization. So that is the ovum and the sperm, meeting up essentially, and the egg being fertilized. And then you have to have implantation. So at any point in this process, you may have infertility problems. You may have problems with ovulation. You may have problems in either the man or the woman associated with fertilization, so either the sperm or the egg. And then you would obviously, the ovulation would be a female problem, and then you may also have problems with implantation, which would also be, a problem in women. That being said, about one-third of fertility cases, as you could see on slide 370, are attributed to women's problems. Again, either ovulation or conception, or potentially even fertilization. Another third are related to the man in the equation. And the other third is potentially either a mixture of male and female problems, or the problem is unknown or undetermined. Both women and men can have infertility, can have problems with fertility. That's why, again, one of the changes that the FDA made with regards to the risk associated with medication use is that we now talk about people of reproductive age, not just women and not just pregnant women per se. Uh, the first part of this slide is also important. About 10% of women in the US have difficulty getting pregnant or staying pregnant. So it's not an uncommon problem. And fertility, whether it's, partial or, more severe infertility is not uncommon. I mean, just this is by no means an indication of what fertility is like, but I can tell you just in the last year, in the a group of military members that is pretty well divided between men and women. I had this is before my retirement, 3 women in my department that were doing IVF. Again, not just anecdotal, but it's not an uncommon problem in fertility, that is. There are some well-known causes of infertility. In men, it's most often caused by one of these issues, varicocele, which happens when the veins in a man's testicles are too large. So enlarged veins in the testicles, and there may be multiple medical etiologies for that. Uh, any other factors that cause a man to make too few sperm or not at all? And also issues associated, and we're going to talk about those in the next slide. And a movement of the sperm. So this may be caused by the shape of the sperm, where the sperm is not as diligent, for lack of a better way of saying it, in um, getting to where it needs to be. Sometimes a man is born with the problems that affect their sperm, whether it's low sperm count or um, the motility or the movement of the sperm. Other times, or those problems are acquired or start later in life, either due to illness, injury. So for example, cystic fibrosis is often causes infertility in men, but that's something that you would clearly see as the disease progresses. Like I said, it can be affected by health or lifestyle. Again, both the sperm count and the motility or mobility of the movement of the sperm. Things like alcohol use, drugs, smoking cigarettes, age, environmental toxins, including pesticides and lead, health problems such as those listed there, including mumps, kidney disease, or hormone issues, including low testosterone. Medicines can affect sperm count and motility, and of course, radiation treatment and chemotherapy. And some uh, um, in some oncology, uh, it's become routine practice to have men who, men of reproductive age store some of their sperm before undergoing cancer treatment, including chemotherapy, just to preserve the health of the sperm for future use if they desire to do so. For women, most causes of infertility are a problem in ovulation. As I said, it could be a problem of ovulation or a problem with implantation. The majority of cases are related to ovulation. A common cause is PCOS or polycystic ovarian syndrome. And uh, in primary ovulation insufficiency is another cause of ovulation problems. Some women have irregular patterns of ovulation, meaning they may have cycles rather regularly, but they don't ovulate in every cycle. That would be primary ovulation insufficiency. Um, and so that's something else to consider. Um, Also, just one more note on primary ovulation insufficiency, that it may also be not just a regular ovulation, but it may be that a woman's ovaries stop working normally before she goes through menopause. And it's not the same thing as early menopause. Okay, so I want to make that clear. It is a different beast. I mean, there may be some, medical causes for some women becoming anovulatory, meaning they don't ovulate despite the fact that they haven't gone through menopause. Less common causes of infertility include blocked fallopian tubes due to pelvic inflammatory disease, endometriosis, or surgery that has either corrected or removed an ectopic pregnancy. Ectopic meaning a pregnancy that occurred outside the uterus, usually in the fallopian tubes. Physical problems of the uterus, so either a inverted uterus or some other, scar tissue or some other malformation of the uterus. That could lead to problems with implantation, but also potentially to problems with conception. Uterine fibroids, which include non-cancers, clumps of tissue and muscle on the walls of the uterus. So again, problems in the shape or um, the function of the uterine cavity, which would lead to difficulty with implantation. Some things that may increase the risk of infertility for women include age, um, smoking, alcohol use, so similar issues as with men. Stress certainly may have a bearing on fertility. Poor diet, so malnourishment, athletic training, being overweight or underweight, so both. Extremes, sexually transmitted diseases, in health problems that cause hormonal changes, such as PCOS, as I mentioned before, and POI, or primary ovarian insufficiency. Infertility can be treated with medication, surgery, artificial insemination, or assisted reproductive technology, or ART, which is essentially a group of different methods that that couples can use, to include IVF, or in vitro fertilization. Um, yeah, uh, I'll just leave it at that. You've probably heard enough or know enough about in vitro that we don't need to go into that. But there are some other art, IVF is not the only form of art. I'll leave it at that. Okay. And we talked about, I think when we talked about hormonal treatments, we talked about ovulatory stimulants such as Clomid or Clomiphene. That is a potential treatment for fertility, that is not, artificial insemination or IVF. So there is obviously psychological distress and stress associated with infertility. And if you've ever seen a patient, or if you have personal experience, or have friends who have experienced infertility, this could be an agonizing um, uh, issue. This may really be a difficult issue to deal with. They experience impact on their social life, impact on their sexual health, impact on the relationship with the partner, especially if partners are, somewhat uh, um, have different expectations or different wants or needs when it comes to their sexual relationship, as opposed to their reproductive functioning, which are not necessarily overlapping. Um, it is, it can be a really difficult issue for women, men, and partners to deal with. As you could see, 40% of women in one study met criteria for a psychiatric disorder. Most commonly anxiety. Second most common is depression. History of depression is a risk factor for recurrence of symptoms during fertility treatment. So even when the woman is undergoing fertility treatment, there may be a high risk for recurrence of a depressive episode. As treatment intensifies, the level of stress increases. There's also other practical considerations, such as financial strain. Infertility treatment is expensive, not always covered by insurance. In fact, not a lot of insurance cover, the full extent of options with regards to art, for example. And so, and of course, there's again all the personal, individual psychological stresses, as well as couple stress. Um, in fact, I mean, you could see some statistics there, where one study showed that 50% of patients had mild depressive symptoms, 19% had moderate to severe depressive symptoms prior to IVF. Treatment dropout more associated with psychological stress. Again, thinking about the burden versus lack of insurance, financial constraints, seems like it's not, those are not the causal factors for treatment dropout. Um, or psychological stress tends to be a higher listed higher in terms of reasons for dropout. Um, um, just keep in mind that unsuccessful treatment affects both partners. 66% of women and 40% of men in one study reporting symptoms of depression following failed IVF. So it's not just a woman or the partner who is conceiving. In the cases of same-sex couples, if women, especially biological women, specifically, not especially. When one of the partners is a designated, the person who is trying to conceive, both could equally be affected by symptoms of depression after a failed IVF trial. And then it could be long lasting. As you could see, one third of participants still experience symptoms 18 months after their failed attempt. You might also see increases in certain psychiatric disorders such as anxiety, including OCD, adjustment disorders, mood disorders in general. You could see psychological response to hormonal treatments, bringing about mood lability or even, outright depression. Um, Obviously, we've talked about relationship stress and um, uh, difficulty in initiating pharmacotherapy because of the expectation that a pregnancy might just be around the corner. So we've already talked about issues associated with treatment of depression during pregnancy. You better believe that somebody who is pretty intent on conception, intent on getting pregnant, is going to take every possible, potential risk of a negative pregnancy outcome very, very seriously. And so they might defer any kind of pharmacotherapy due to the expectation that a pregnancy might just be around the corner. And so that brings about, a significant amount of strain. Slide 381, in one Danish study found increased risk of psychiatric disorders for women who did not get pregnant after fertility evaluation. And you could see the risk there. Very significant risk for alcohol and substance abuse in that study, and even things like schizophrenia and other mental disorders. So including higher risk of hospitalization for mental disorders compared to women that went on to have a successful pregnancy. Um, In a 2017 review, the patients were women in 26 studies. Diagnosis of infertility or reproductive disorder associated with infertility. Women with infertility had higher rates of psychiatric disorders and endometrial cancer than the general population. And women with infertility related to PCOS more likely to develop cardiovascular disease and metabolic disorders such as diabetes than the general population. So there may be long-term health outcomes that are associated with infertility. Again, very stressful time and condition. So as I mentioned before, clomiphene is an agent that can act as a stimulant of ovulation. So, in the 20 to 30% of infertility in women that is associated with lack of ovulation, clomiphene acts as an anti-estrogen at the hypothalamus to increase pulse frequency of the luteinizing hormone. You don't need to know what that means, but that's what it does. Um, and uh, it is typically well tolerated. Main issue associated with clomiphene is that you could have all the symptoms, including hot flashes resembling those that you see in menopause. And something that patients need to know about is that they can have multiple gestations, meaning that they could have multiple children. So anything that's going to stimulate ovulation may trigger multiple ovulation, meaning that more than one egg is released during a cycle, which means that more than one egg may be fertilized. Um, so the woman must be willing, or the couple may be willing, if they are a couple, must be willing to conceive multiples if they're going to use clomiphene or clomid. Obviously, it's contraindicated in pregnancy, so you don't want to use it if the woman's already pregnant. So you need a pregnancy test at every stage of the game, or if you have ovarian cyst or liver disease. Here's some other medications that may be used, including human menopausal gonadotropin or HMG. Um, Also used for women who don't ovulate specifically because of issues with their pituitary gland. You may use FSH or follicle stimulating hormones and gonadotropin releasing hormone analogs. Those are, again, all treatments associated with um, ovulation dysfunction. Uh, Another option is metformin. Yes, the glucophage or the medicine that is used to treat women and men with diabetes. So treat diabetes. This medicine is used for women who have insulin resistance and or PCOS. It helps to lower the high levels of male hormones in women with this conditions, not in every woman, and especially not, not every woman with diabetes. But sometimes it can be used in combination with clomiphene or FSH in order to, help with these issues. Bromocriptine or Parlodel can be used with for ovulation problems for women who hyperprolactinemia or higher levels of prolactin. Of course, we want to consider psychiatric treatments. So consider short-term treatments for most acute symptoms if possible. So if you have an anxiety condition, for example, pre-IVF, the woman is, um, having acute episodes of anxiety and maybe may create some difficulties with regards to the hormone therapy that is required prior to the in vitro. Low dose, short-term use of a benzodiazepine may be indicated, or if they have anxiety associated with surgical procedures that may be part of their treatment regimen, that may be an appropriate use. You want to obviously assess for untreated depression, anxiety, and other psychiatric disorders and educate the patient and the partner, if possible, about the potential impact of stress on fertility. There's no findings that say that relieving stress alone is going to lead to pregnancy, but certainly can alleviate some of the or can be helpful and certainly alleviate quality of life issues and prevent dropouts. You may actually have a conversation about delaying fertility treatment until the psychiatric symptoms are stabilized and resolved. In some cases, especially if you have severe depression or if you have potential complications of depression, such as malnourishment, self-neglect, or suicidal ideation, you need to address the psychiatric symptoms, before fertility treatment should be continued. And of course, you want to maximize the use of non-pharmacological treatments. Um, Consider individual and group interventions. Make sure to include the partner, if possible, if you're allowed to, if they permit you to. Uh, in there are some findings that indicate that conception and birth rates are significantly higher in programs that include mind and body approach. So you want to keep those in mind. Treat psychiatric symptoms in cases in which psychotherapy has not been effective and the symptoms are severe or incapacitating. Just keep in mind that some patients may just be able to taper off the medications once the pregnancy is established. Not true in every case, but it is possible. I'm realizing I don't really have time to go into intimate partner or sexual based violence. So I'll send you the slides if I haven't done so yet. You may review them on your own. Just want to make sure, to understand it from a sex, perspective. We've already talked about the fact that most victims are women, that, gender minorities, such as, transgender women, gay men and gay women are also at higher risk of being victimized. Keep in mind that there are risk factors for victimization and for perpetrating domestic violence that are psychiatrically related, including PTSD and substance abuse, and those are things that we can treat. So we should treat both, potential victims and perpetrators for the conditions that make it more likely that they will be either victims or victimized, and or perpetrate abuse. Um, yeah, and I guess that's all I'll say about that because I don't want to go over time. I'll end by saying, once again, as I mentioned, my email from my Alliant email may be unreliable in the long term, but I still have a Yahoo account. I've had it for years. I may not respond as quickly because there's a lot of emails that come through that account, but I'll try to get back with you. It truly has been a pleasure for me to, you know, share this ride or go on this ride with you guys. And I wish there was more time because I definitely, want to hear from you and have more things to say. But I don't want to keep you. So thank you so much for your time and attention and good luck.